Welcome to Clinical Thinking Lab episode 6. This episode is different from the previous 5. Instead of discussing one new case, today I am going to rapidly review the first 5 cases from this series. For each case, I will briefly cover how the patient presented, the diagnosis and the major differential diagnosis, the causes and pathophysiology, the key investigation, the treatment hierarchy, the major complications, and most importantly, the one clinical decision that changed management. These 5 episodes cover very different diseases, but together they taught one common lesson. Clinical thinking is not simply remembering a diagnosis. It is identifying the immediate threat, understanding the physiology, taking action, reassessing the patient, and changing the plan when the new information appears. So let us rapidly revisit 5 cases and 5 decisions. Our first case was acute mesenteric ischemia. The patient was a 65-year-old with atrial fibrillation who developed sudden severe abdominal pain and vomiting. The most important early clue was that the pain was much more severe than the initial abdominal examination. This is the classic idea of pain out of proportion to examination. The diagnosis was acute embolic mesenteric ischemia caused by an obstruction of the superior mesenteric artery. Important differential diagnoses included acute pancreatitis, intestinal obstruction, perforated viscous, biliary disease, and gastroenteritis. But the history of atrial fibrillation, sudden onset, and disproportionate pain made a vascular emergency more concerning. There are 4 major mechanisms of acute mesenteric ischemia. The first is an atrial embolus, commonly originating from the heart in atrial fibrillation. The second is thrombosis of a previously diseased mesenteric artery. The third is non-occlusive mesenteric ischemia, where severe low flow states or intense vasoconstriction reduce intestinal perfusion without a fixed arterial blockage. The fourth is mesenteric venous thrombosis, which interferes with venous drainage. The basic pathophysiology is interruption of intestinal blood flow. This causes mucosal ischemia, bowel wall injury, bacterial translocation, metabolic acidosis, and rising lactate. Without reperfusion, ischemia progresses to transmural necrosis, perforation, peritonitis, septic shock, and death. The key diagnostic investigation is urgent CT angiography. CT angiography identifies the location and type of vascular obstruction and may show signs of bowel injury. Treatment starts with immediate resuscitation, bowel rest, broad spectrum antibiotics, and anticoagulation when appropriate. But anticoagulation alone does not reopen a critically occluded artery. A proven SMA occlusion requires urgent evaluation for endovascular or open revascularization. If the patient develops guarding, rigidity, rebound tenderness, perforation, or other evidence of necrotic bowel, the priority changes to emergency laparotomy with assessment and resection of non-viable bowel. The major complications are bowel infarction, perforation, sepsis, multi-organ failure, and short bowel syndrome following extensive resection. The key decision from episode 1 was do not observe a proven mesenteric arterial occlusion and wait for the abdomen to become rigid. By the time obvious peritonitis develops, irreversible bowel necrosis may already be present. Our second case involved a patient with primary adrenal insufficiency who developed vomiting, weakness, confusion, and severe hypotension after missing steroid replacement during an acute illness. The investigation showed hyponatremia, hyperkalemia, and hypoglycemia. The ECG showed peak T waves. This patient had two connected but distinct problems. The immediate emergency was malignant hyperkalemia with ECG changes. The underlying disease was adrenal crisis. Important differential diagnosis included septic shock, severe dehydration, acute kidney injury, gastroenteritis illnesses, medication-induced hyperkalemia, and other causes of hypoglycemia. The pathophysiology involves deficiency of cortisol, and in primary adrenal insufficiency, aldosterone is also deficient. Cortisol is necessary for a normal vascular response to endogenous and administered catecholamines. Without adequate cortisol, vascular tone falls and hypotension may respond poorly to fluids and vasopressors. Aldosterone normally promotes sodium retention and potassium excretion. Therefore, aldosterone deficiency causes sodium loss, volume depletion, hypotension, and hyperkalemia. Cortisol deficiency also impairs gluconeogenesis and contributes to hypoglycemia, especially during illness or fasting. The diagnosis is clinical during the emergency. Serum cortisol and ACTS should be drawn before treatment when this can be done immediately. But treatment must never be delayed while waiting for the result. In this case, treatment had two simultaneous pathways. Because hyperkalemia was producing ECG changes, IV calcium was given first to stabilize the myocardium. Insulin with dextrose shifted potassium into the cells. The adrenal crisis itself required immediate IV hydrocortisone, isotonic fluid resuscitation, and glucose when hypoglycemia was present. If severe hypotension continued despite steroids and adequate resuscitation, norepinephrine was required to support perfusion. The major complications of untreated adrenal crisis include refractory shock, malignant arrhythmia, severe hypoglycemia, seizures, coma, and death. The key decision was treat suspected adrenal crisis before confirmation. A cortisol result can help establish the diagnosis later, but it cannot rescue a patient if treatment is delayed during shock. Our third case was a 72-year-old patient who had recently undergone knee replacement. He developed sudden shortness of breath, pleuritic chest pain, near syncope, and hypotension. Clinical findings included jugular venous distension, possible unilateral calf swelling, and a relatively clear chest X-ray. Bedside echocardiography demonstrated right ventricular dilation and septal bowing. Troponin and BNP were elevated. The diagnosis was high-risk pulmonary embolism causing obstructive shock. Important differential diagnosis included acute right ventricular myocardial infarction, acute coronary syndrome, aortic dissection, tension pneumothorax, and cardiac tamponade. The likely source was venous thromboembolism related to recent surgery and immobility. The clot obstructed pulmonary arterial circulation. This abruptly increased pulmonary vascular resistance and created severe right ventricular afterload. The right ventricle dilated and began to fail. As the right ventricle enlarged, the interventricular septum shifted toward the left ventricle. Left ventricular filling failed, cardiac output decreased, and the patient developed obstructive shock. The elevated troponin did not necessarily represent coronary plaque rupture. It could represent myocardial injury caused by acute right ventricular pressure overload and ischemia. This was one of the most important lessons from the episode. Troponin tells us that myocardial injury occurred. It does not independently tell us why. CT pulmonary angiography is the major diagnostic test when the patient can safely undergo imaging. But CT pulmonary angiography is not a treatment. Management includes oxygen support, anticoagulation when appropriate, careful hemodynamic support, and urgent consideration of reperfusion. Large indiscriminate fluid boluses can worsen right ventricular dilation and septal shift. A small, carefully assessed bolus may help selected preload depleted patients, but norepinephrine is often needed when profound hypotension persists. For pulmonary embolism with persistent hypotension or established cardiopulmonary failure, advanced reperfusion may include systemic thrombolysis, catheter-based therapy, mechanical thrombectomy, or surgical embolectomy. The selection depends on bleeding risks, the patient's condition, and local expertise. Our patient received alteplase and initially improved, but then developed intracranial hemorrhage. That forced another reprioritization. Stop thrombolytic and anticoagulant treatment, stabilize the brain injury, reverse the coagulation defect when indicated, and urgently involve neurosurgery. The key decision from episode 3 was treat the physiology, not the biomarker. An elevated troponin should refine the risk assessment, but it should not make us ignore the entire clinical picture. Our fourth patient was a 67-year-old woman with fever, productive cough, confusion, hypotension, and a right lower lobe pneumonia. Her initial diagnosis was septic shock. That diagnosis was reasonable. She received cultures, antibiotics, cautious fluid resuscitation, and norepinephrine. But despite treatment, the shock worsened. She remained hypotensive, developed oliguria, and showed evidence of persistent hypoperfusion. A repeat bedside echocardiogram showed an ejection fraction of 20% with diffuse hypokinesis. Her previous ejection fraction had been 60%. This new information changed the clinical picture. The patient no longer had only distributed shock from vasodilation. She also had acute myocardial dysfunction contributing to low cardiac output. The updated diagnosis was septic shock complicated by sepsis-induced cardiomyopathy. Important differential diagnoses included acute myocardial infarction, myocarditis, stress cardiomyopathy, and previously unrecognized chronic systolic heart failure. Sepsis-induced myocardial dysfunction is thought to result from a complex combination of inflammatory mediators, nitric oxide pathways, mitochondrial dysfunction, metabolic disturbances, and altered catecholamine responsiveness. The key echocardiographic pattern in this case was a global or diffuse hypokinesis. A coronary infarction more commonly produces a regional wall motion abnormality corresponding to a vascular territory. That distinction is helpful, although no single echocardiographic finding should be interpreted in isolation. Treatment begins with treating the sepsis itself. Early antibiotics, source control, individualized fluid resuscitation, and vasopressor support. Norepinephrine supports vascular tone and arterial pressure. When the patient has cardiac dysfunction with persistent hypoperfusion, despite an adequate volume state and adequate volume pressure, an inotrope may be added. One accepted strategy is dobutamine in addition to norepinephrine. The purpose is not simply to increase the number on the ejection fraction. The goal is to improve forward flow and tissue perfusion when reduced contractility is contributing to shock. In our case, the ejection fraction later improved from 20% to approximately 55%. That rapidly recovery supported transient sepsis-induced myocardial dysfunction rather than chronic systolic heart failure. The major complications include persistent mixed shock, arrhythmia, pulmonary edema, multi-organ failure, and death. The key decision was new physiology should update the diagnosis. The initial diagnosis of septic shock was not necessarily wrong. It had become incomplete. Our fifth case was a 64-year-old man presenting with fever, melena, weakness, dizziness, and collapse. He had chronic kidney disease stage 4, diabetes, and ischemic cardiomyopathy. His blood pressure was 72/40, and he was pale, confused, and poorly perfused. His hemoglobin was 6.2, his lactate was 6.9, his creatinine had risen above baseline. His potassium was 6.8, and the ECG showed peak T waves. Urinalysis suggested a urinary source of infection. This patient did not have one diagnosis. He had several simultaneous emergencies of an upper GI bleed causing a hemorrhagic component of shock, urosepsis causing distributive shock, acute kidney injury on chronic kidney disease, metabolic acidosis, and malignant hyperkalemia with ECG changes. Every specialist was focused on a real problem. The GI specialist saw the bleeding. The intensivist saw septic shock. The nephrologist saw the potassium. The difficult task was not deciding who was correct. The task was deciding what would kill the patient first, what could be treated simultaneously, and what had to wait. Because hyperkalemia had produced ECG changes, IV calcium came first. Calcium does not remove potassium from the body. It stabilizes the myocardium and reduces immediate risks of fatal arrhythmia. Insulin with dextrose then shifts potassium intracellularly. At the same time, other parts of resuscitation must proceed in parallel. Cardiac monitoring and large bore access, blood cultures, immediate broad spectrum antibiotics, type and cross match, pack red cell transfusion, judicial steroid resuscitation, norepinephrine for persistent severe hypotension, and early nephrology involvement for dialysis planning. The blood transfusion was not merely treating an abnormal hemoglobin result. In severe hemorrhage, blood helps restore oxygen carrying capacity and circulating volume. Endoscopy remained important, but immediately transporting a patient with untreated malignant hyperkalemia and profound shock for a procedure would have been dangerous. Then the case became even more complex when the patient developed an inferior ST elevation MI while the GI bleeding continued. Fibrinolysis would carry an unacceptable bleeding risk. Primary percutaneous intervention was the more appropriate reperfusion pathway, but antiplatelet and anticoagulant decisions still required individualized discussion among interventional cardiology, gastroenterology, and critical care. The key decision from episode 5 was Treat the immediate killer while mobilizing parallel care. Prioritization does not mean ignoring 4 problems to treat one. It means clearly identifying the first life-saving intervention while directing the rest of the team simultaneously. Before finishing the review, here are 5 corrections that matter. Correction number 1. CT pulmonary angiography diagnoses pulmonary embolism. It does not treat pulmonary embolism. Correction number 2. Acute arterial mesenteric ischemia generally requires urgent reperfusion planning. Routine systemic thrombolysis should not be presented as the universal main treatment. Correction number 3. Hydrocortisone in adrenal crisis restores the hormonal support required for normal vascular responsiveness to catecholamines. It does not simply sensitize the cardiac membrane. Correction number 4. Diffuse hypokinesis supports global myocardial dysfunction. Regional wall motion abnormalities raise greater concern for focal coronary ischemia, although the whole clinical context must still be considered. Correction number 5. Prioritization does not mean doing only one task. In critical illness, one intervention may come first, while antibiotics, transfusion, monitoring, vasopressors, and specialist mobilization occur in parallel. These corrections are valuable because errors discovered during recall are not failures. They are high-yield learning targets. The facts we misremember are often the exact facts we need to revisit most deliberately. Although these were 5 different cases, one clinical framework connected all of them. The first step is threat. What is the most likely to kill the patient first? Is it arrhythmia, shock, bowel necrosis, obstructed pulmonary circulation, or uncontrolled hemorrhage? The second step is physiology. What physiologic process explains the instability? Is the problem electrical, distributive, obstructive, hemorrhagic, or cardiogenic? The third step is action. What intervention can meaningfully change the patient's outcome now? Not after every investigation is complete, not after every consultant arrives. What must happen now? The fourth step is reassess. Did the blood pressure improve? Did the potassium fall? Did perfusion recover? Did the abdominal examination change? Did the echocardiogram reveal something new? The fifth step is update. Does the original diagnosis still explain everything? Has a new complication appeared? Has the dominant physiology changed? And does the treatment plan now need to change? This is the framework I want to carry into future clinical thinking lab cases. Threat, physiology, action, reassess, and update. The goal is not to be right once. The goal is to keep making the safest decision as the patient changes. Now let us finish with 5 rapid recall questions. Let's pause before briefly after each question and try to answer before I explain. Question number 1. In acute mesenteric ischemia, what finding changes the plan for revascularization alone to urgent abdominal exploration? The answer is peritonitis, perforation, or evidence of necrotic bowel. Question number 2. Why should we not wait for a cortisol result before treating suspected adrenal crisis? Because adrenal crisis is immediately life-threatening and hydrocortisone treatment should begin before confirmatory results. when severe symptoms or shock are present. Question number 3. Why can troponin rise in pulmonary embolism without an acute coronary occlusion? Because acute right ventricular pressure overload can cause right ventricular ischemia and myocardial injury. Question number 4. Which pattern more strongly supports sepsis-induced myocardial dysfunction, diffuse or regional hypokinesis? Diffuse or global dysfunction is more consistent with sepsis-induced cardiomyopathy. Regional dysfunction raises greater concern for coronary ischemia. Question number 5. In a patient with malignant hyperkalemia, septic shock, and active bleeding, what happens first and what happens in parallel? IV calcium comes first when ECG changes are present. At the same time, potassium shifting, antibiotics, transfusion, hemodynamic support, and dialysis planning must begin in parallel. If we can answer these 5 questions without looking back, we have retained the core lessons of this week. These are the principal guidelines and reviews used to maintain medical accuracy in this rapid review. They include guidance on acute mesenteric ischemia, adrenal crisis, pulmonary embolism, sepsis-induced myocardial dysfunction, septic shock, and acute hyperkalemia. The purpose of clinical thinking lab is not to replace formal guidelines or specialist consultation. It is to practice how clinical reasoning changes when the patient becomes unstable, when new information appears, or when multiple emergencies compete for priority. Across these 5 cases, my biggest lesson was this: do not merely ask what disease does this patient have. Ask what is killing this patient now, what physiology explains it, and what decision changes the outcome. This was Clinical Thinking Lab episode 6. 5 cases, 5 decisions, and one reusable framework. Threat, physiology, action, reassess, update. This is the ANG experience. Thank you for watching and listening. See you in the next.